Hi, my name is Alyssa, and this is Medisin, where learning is always in style. Today, we'll be talking about electrocardiograms, or ECGs. By the end of this video, you will have an understanding on the following topics: the preparation of an ECG, a systematic approach to reading ECGs, and recognizing features of normal sinus rhythm. Before we start, make sure to like, comment, and subscribe. Also, follow our Instagram at MedisinStyle for more content on life as a med student and study review. Okay, let's get started. We have discussed the conduction system of the heart in two prior videos. In essence, it's the electrical system of the heart that coordinates the muscle contraction of each heartbeat. The system begins in the SA node, travels through the internodal branches to the AV node, the bundle of His, to the left and right bundle branches, and the Purkinje fibers. When this system becomes problematic, the heart does not contract properly or pump blood as required, which may lead to problems. Any abnormal changes in the electrical conduction are known as arrhythmias. We can assess the conduction system and myocardial function of the heart with an electrocardiogram, or ECG. An ECG requires electrodes on the upper and lower extremities, as well as along the left side of the chest, or precordium. In total, there are 12 leads, or vectors, which assess cardiac function from 12 different perspectives. Leads 2, 3, and AVF assess the inferior aspects of the heart. Leads 1, AVL, AVR, V5, and V6 assess the lateral aspects of the heart. Leads V3 and V4 assess the anterior aspects of the heart. And leads V1 and V2 assess the septal regions of the heart. Now let's understand the ECG paper. The x-axis describes time. One big box corresponds to 200 milliseconds, or 0.2 seconds. That means that each little box is 40 milliseconds, or 0.04 seconds. The y-axis corresponds to wave amplitude. Every ECG strip should have a legend to verify the voltage that corresponds to a big square. Generally, one big box, vertically, corresponds with 0.5 millivolts. A normal ECG wave has the same basic parts: the P wave, the QRS complex, and the T waves. The P wave corresponds to the atrial depolarization, which is normally initiated in the SA node. The QRS complex corresponds with the ventricular depolarization, which is normally initiated in the AV node following SA node stimulation. The T wave corresponds to ventricular repolarization. We can also describe intervals, or times between different waves, on the ECG. The PR interval describes the length of time between the start of the P wave and the start of the QRS complex. The QRS interval occurs from the beginning of the Q wave to the end of the S wave. The ST segment occurs from the end of S to the start of the T wave. We should also note that there is an isoelectric line, which corresponds to the middle point from which we determine positive and negative. If you ever get confused about where the isoelectric line is, look at the segment between the end of the T wave and the start of the next P wave. There is no electrical activity here in the heart, which makes this the isoelectric line. Now let's use this information to read ECGs. When we read an ECG, we want to assess for 5 basic characteristics: axis, rhythm, rate, intervals, and wave morphologies. To understand all this, let's consider our patient, Anthony. Anthony presents to the clinic for a pre-operative clearance visit. As part of that appointment, he has been ordered an ECG. First, let's assess the axis of Anthony's ECG. The axis describes the general direction of electrical spread within the heart. To assess the axis, we look at leads 1, 2, and 3. A normal axis goes from the 11 o'clock position within the heart to the 5 o'clock position, which translates to positive leads 1 and 2. A right axis deviation occurs with a negative lead 1, positive lead 2, and even more positive lead 3. This is often associated with right ventricular hypertrophy. A left axis deviation occurs with a positive lead 1 and negative leads 2 and 3. This is often associated with conduction abnormalities of the heart. Anthony has positive leads 1 and 2, which translates to a normal axis. Second, we will assess the rhythm. The rhythm describes the regularity of the contractions. We can describe the rhythm as regular, regularly irregular, or irregularly irregular. A regular rhythm describes an equal and constant interval between consecutive R waves, which means that there is a constant amount of time between each heartbeat. A regularly irregular rhythm describes a recurrent pattern of irregular beats. For example, a person has 2 beats, followed by a long pause, then another 2 beats, then a long pause, and so on and so forth. An irregularly irregular rhythm describes a completely disorganized pattern of heartbeats. An irregularly irregular rhythm is pathognomonic for atrial fibrillation. Anthony's R waves are equidistant apart. The interval between each R wave is 3.5 big boxes, or about 0.7 seconds. This means Anthony has a regular rhythm. Third, we assess for rate, which describes the number of heartbeats per minute. For a patient with a regular rhythm, the rate is estimated by counting the number of big boxes between 2 consecutive R waves. Then we divide 300 by this number of boxes. Things get a little more complicated, though, if the heart rate is irregular. Since rhythm strips traditionally measure the heart rhythm over a 10-second period, we can count the number of R waves in one strip and multiply this number by 6 to estimate the average heart rate in beats per minute when the beats are irregular. Since Anthony has a regular rhythm, we will divide 300 by the number of big boxes between the R intervals, which is 3.5. Therefore, his heart rate is about 85 beats per minute. A normal heart rate is 60 to 100 beats per minute. Bradycardia occurs with a heart rate less than 60, and tachycardia occurs with a heart rate greater than 100. Therefore, Anthony has a completely normal heart rate. Fourth, we will assess the length of the various intervals. The PR interval should measure between 120 and 200 milliseconds, or 0.12 and 0.20 seconds. This means the PR interval should be between 3 and 5 small boxes in length. Anything longer may suggest a conduction block. The QRS interval should last no longer than 80 milliseconds, or 0.08 seconds, which is 2 small boxes. A wide QRS complex suggests that the ventricular contraction is not initiated by the SA node relaying to the AV node, but rather the AV node firing independently. These are the 2 main intervals to assess on ECG, but note that there are other intervals, like the QT interval, that is clinically relevant, especially in the context of QTC prolongation as a side effect of medications like antipsychotics. For our purposes, we want to make sure that the T wave occurs less than halfway between the end of the QRS and the next P wave. Anthony's PR interval is about 3 small boxes, which is 0.12 seconds. The QRS complex is about 2 small boxes wide, which is about 0.08 seconds. These are totally normal intervals. Fifth and finally, we will assess the wave morphologies. We will discuss these in the context of Anthony's ECG. A normal ECG will have an upright P wave in leads 1, 2, and AVF, and a negative P wave in AVR. Anthony has these. Moreover, each P wave should be followed by a QRS complex, and each QRS complex should be preceded by a P wave. Finally, we will need to assess the precordial leads, which are V1 through V6. We expect V1 to have a more negative QRS, and V6 to have a more positive QRS. There should be a transition between negative to positive happening between V2 through V5. It should not transition to positive before V2 or after V5. Anthony's V1 has a negative QRS, and he transitions to a more positive QRS in lead 5. This is a normal progression of the precordial leads. All these features suggest that the heart is beating normally with initiation of conduction from the sinoatrial node, or SA node. Therefore, we call this normal sinus rhythm. By studying Anthony's ECG, we have learned about the features of normal sinus rhythm. In summary, a normal sinus rhythm has a normal axis with leads 1 and 2 having a positive QRS, a regular rhythm, a rate between 60 and 100 beats per minute, a P wave followed by a QRS, and every QRS being preceded by a P wave, a PR interval less than 1 big box, and a QRS complex that is less than 2 small boxes. The P waves should also be positive in leads 1, 2, and AVF, as well as negative in lead AVR. Finally, the QRS direction in the precordial leads should progress from negative to positive after V1, but before V6. As a general recap, today we discussed the conduction system of the heart, the setup and preparation of an ECG, a systematic approach to reading ECGs, and features of normal sinus rhythm. Stay tuned for our next video about different arrhythmias on ECG. That's it. Please be sure to like, comment, and subscribe. Also, follow our Instagram @MedisinStyle for more content. My name is Alyssa, and this is Medisin, where learning is always in style.